Yes. Thanks for the introduction. Although if things need absolute clarification, we can do that, of course. In the meantime, sorry I can't address you in Swedish. My Swedish is a little rusty or non-existing, so we have to do it in English. To be absolutely clear, these are my disclosures of conflicts of interest. I try to spread interest so that I can stay neutral, and I approach everything evidence-based. This is my core business. This is where I come from. Acute abdomen, anything related to that, including the surgery and the diagnostics. Acute pancreatitis, chronic pancreatitis surgery. But my main practice is intestinal failure and complex abdomen as a national referral unit for the Netherlands. With that comes complex abdominal wall reconstructions. I work in the Amsterdam University Medical Centers, which is actually I work in the Amsterdam Medical Center, the AMC, but it has now united with the Free University Medical Center, with two big universities that now have joined together, which is too big actually, but I just stay on my side in the AMC. But part of our surgical department has moved to the Free University Hospital site of the Amsterdam UMC, so that makes things really complicated. But I saw here at Sahlgrenska that you also have different buildings for different disciplines, and so you're used to it. I'm not. I'm still not. Part with it comes with doing complex patients is also awareness of patient safety, because in these patients, if anything goes wrong, everything goes wrong. And with that hand in hand, the prevention of surgical complications. This is an example of how my patients look before surgery and after surgery. Most of them, over 90%, are becoming what we call have their intestinal autonomy back, so they're free from parenteral nutrition. And the impact of surgical site infections is very big. I'm talking about surgical site infections. That is my topic of today. It gives an increase in length of stay in hospital, an increase in surgical procedures, re-interventions, percutaneous interventions, increased readmission rate, antibiotic prescribing, very important when we talk about antimicrobial resistance. Cosmetic impact, of course, if you have a wound infection or a burst of your wound or both. A negative impact on cancer survival after cancer surgery, also very important. Increased incisional hernia rate, and the economic burden, resource usage. The average cost of a surgical site infection is 5,000 to 10,000 pounds per SSI. Now, every detail matters, so you need the surveillance of your entire surgical pathway, optimization of the pathway. Safety going hand in hand with prevention of complications. The first thing that we did about that was already some time ago when we designed the SURPASS safety checklist, which is more comprehensive than the WHO checklist. Actually, the SURPASS is what we use in the Netherlands, and it's also in the national guideline, because it starts at pre-admission in the outpatient clinic, and it has different checks in the different locations of that pathway: ward, holding, OR, recovery, again back to the ward, and then discharge to home. And each is attached to a checklist, which is now fully digital and integrated in our hospital patient information system. We published that also now a while ago in November 2010 in New England Journal of Medicine. It's about the same time that the WHO published their results. we did that simultaneously, not knowing of each other's work. But the big difference is that the surpass checklist is covering the entire pathway and not only in the OR. What happened is that, as you can see, is that if you look at the complications per 100 patients, then we had the intervention hospitals and we had the control hospitals that just did business as usual, and the control hospitals had the complications of before implementation of nothing was 30 per 100, and after, in the post-implementation phase, which actually they didn't implement anything, the same, no difference. And in the intervention hospitals that used the surpass checklist, the complications per 100 went down from 27 to 16.7, which is an absolute risk reduction of 10.6. So that was a huge success. Mortality with our checklist dropped more than of the WHO checklist. So this is what we use in the Netherlands. But it's all about that surgical pathway monitoring and optimizing. If you look at that surgical pathway, you optimize, of course, the right indication for the right patient, the right communication about what you're doing, what you're going to do, what they're going to expect, but also what the part is that the patient needs to do, and that touches upon prehabilitation, which means quit smoking, lose weight, etc., and the right technology. Now, I'll zoom into a little bit what I mean with the right technology, because again, that is using that surgical pathway. And in that surgical pathway, besides the checks that I showed you, you can use a bundle of interventions to know that are known to prevent SSI. And again, that's also in the same pathway. So if you look at this again, which we did for the safety checklist, but also here you have the things you can do pre-admission, like the prehabilitation, that weight loss, stop smoking, that regulate diabetes, that all reduces SSI. And then in each part of the surgical pathway, you have your interventions to reduce SSI. That's kind of the similar way that the WHO projected their recommendations in the implementation manual, also using this surgical pathway before surgery, during surgery, and after surgery. So that's the way they have to look at it. And each of these interventions are in a different section of this pathway, and also are attached to different people who are responsible, healthcare personnel that is responsible to execute those interventions. It's another example following the same principle of that surgical pathway. So that is the first thing I want to get across, is that use that mental pathway to implement these interventions that reduce SSI. Now, what doesn't help is that the guidelines disagree on how to propose the ideal bundle of SSI reduction. If you look at the NICE guidelines, WHO, CDC, and the American College of Surgeons guidelines, you see, if you just eyeball this by looking at the colors, that they don't agree on some of the interventions. So in green, it's a positive recommendation. In brownish, it's a negative recommendation, and if it's yellow, it's kind of in between, or just a sub-recommendation. That doesn't really help. So I think we do need a bundle. If you look at, for example, this systematic review, I think this is one of the better ones, showing you a risk reduction of about 0.6 with a significant confidence interval, using a bundle. Anything left of the red vertical line is significant. But the thing is that all these bundles are different. There isn't a single bundle in a single study with the same bundle as the other study. So maybe having a bundle in place is more important than the parts of that, which is not completely true, but I'll show you. So these bundles reduce superficial SSI by 40%. That's extraordinary. Now, my PhD group did a more recent systematic review of bundle studies, and we plotted that as a forest plot of an interrupted time series. You don't need to know what interrupted time series are, but what you can see in this forest plot, that if you look at the three panels here, the top one is that the proportion of the evidence-based of the interventions are more than 75% is evidence-based in the bundle, and then you have a significant reduction. Prevention of SSI post-implementation, left of the 0 in this. If you have in the middle panel 50 to 75% evidence-based, still a significant reduction, but it's less. If you have less than 50% evidence-based, you see it's almost, there's something happening with the sound, it almost crosses the 0 being non-significant. Do we need to adjust something? Okay, I just talked. So having bundle elements in place that are evidence-based is very important. What we did is our evidence-based bundle in the APOS trial, the effect of enhanced perioperative care and health program, we used a limited set of interventions all with a proven effect that could be done without new investments. And that's something that is a matter of debate, because I think some of these interventions that I'll show you next may need some investments, but they pay back by reducing SSI, and combine them as well. Okay, this is our evidence-based bundle. Timing and redosing of the surgical antibiotic prophylaxis. Yeah, maybe we need to switch microphones because. Okay. Okay. Well, doing it. Does it work? Yeah. Right. Okay. So the timing, the homeostasis during surgery. Part of that was doing what the anesthesiologist is doing, normothermia, including pre-warming, hyperoxygenation, normovolemia, and normoglycemia. Then the surgical site handling, the part that the surgeon's doing, hair removal with a clipper or no removal, skin prep with higher doses of corexidin and alcohol, wound irrigation before wound closure, and triclosan-coated sutures. That's what we did in our trial, and the results will be there soon. The CDC guidelines in 2017 were published a year later after they actually have been issued, because there was some debate. What I actually don't like about the CDC guidelines is that there is some politics in it, and you see, although they resemble the WHO guidelines, but not in all. The WHO global guidelines, it was a very interesting process to be part of, because it is super 300% evidence-based. It's so, these systematic reviews were so scrutinized. I've done in my life a lot of systematic reviews, but this has beaten everything. Many disciplines were part of the guidelines. You can read that even patients were represented. And the members of the guideline development group were from more than 50 different countries and from all the continents in the world. These guidelines were issued at the end of 2016, and they were updated beginning of 2019. The first guidelines were published in Lancet Infectious Disease in 2 papers in the same issue, the end of 2016. What I now want to do is give you an update on various interventions, so you have an overview of all of it, and I've updated all the evidence up to today. So there's no need to look any further. So that's easy. Preoperative bathing. It's not something that the bathing or showering itself prior to surgery has a lot of evidence, but it's good practice. What has evidence is that if you do the it's normal to do the bathing and shower prior to surgery and have that as part of your bundle, but you don't need to do that with complicated soap containing chlorhexidine gluconate, because plain soap is good enough. There's no statistical difference in the effect. Mupirocin for Staph aureus carriers. A lot of debate about that, but if you look at the meta-analysis at that time of the guidelines, there is a significant reduction with an odds ratio of about 0.5 in favor of the use of mupirocin for Staph aureus carriers. The problem is, do you screen everyone for being a carrier, or do you only treat the known carriers, or do you treat all without screening? And that is something that is an ongoing debate. We've now decided to follow the WHO guideline, saying that in thoracic and orthopedic surgery, because that's where the evidence lies, and known nasal carriers of Staph aureus, we give mupirocin 2%, which was a strong recommendation. And other types of surgery, there's just not enough evidence, because that was not the focus of most of these studies. It's only a conditional recommendation to use it. And for other types of surgery, it would go beyond what's reasonable to treat everyone without knowing whether they're a carrier. For colorectal surgery, mechanical bowel preparation is also has been a debate for, I think, the last 10 years. For our national guideline, just finished 2 weeks ago, the systematic review was done. The systematic review finished 2 weeks ago. So this is your update for today. The summary results of bowel prep and its effect on surgical site infections. For colorectal surgery, if you give mechanical bowel prep with an oral antibiotic, it has a significant reduction in the relative risk of SSI. You can see the relative risk and the confidence interval. If you give oral antibiotics only, without the mechanical bowel prep, it's still a significant reduction. It seems that there is maybe a little bit less effect, but the confidence intervals overlap. If you only give mechanical bowel preparation, so the lavage of the colon, there's no effect at all. So that's something that we shouldn't do anymore. But there's also an interesting effect on the anastomotic leakage, which is the big fear of colorectal surgery. Mechanical bowel prep and oral antibiotics, but also the oral antibiotics only, give a significant reduction of the anastomotic leak. How good is that? Mechanical bowel prep alone, no effect. The timing of antibiotic prophylaxis. It is for certain, and these things are for certain, that an increased risk of SSI when the prophylaxis is administered more than 2 hours before incision. That's too early. That's excluding vancomycin, but that I think is a very strange prophylaxis, but they do that in the US for some surgery. So more than 2 hours is not good, and any time post-incision also gives you an increased risk, so that's also no good. So that leaves the debate whether it should be in the hour before the incision or in the 2 hours before incision. And we looked at this in many patients, and we compared that of all the studies that looked at different time intervals. And the conclusion was, if you look at this forest plot, if you look at the black diamond, it crosses the vertical 1. That means that there is no difference between 0 to 60 minutes or 60 to 120 minutes. So the WHO guideline says prophylaxis within 2 hours, and it doesn't need to be more specific than that. Now, if we're talking about antimicrobial resistance, I think one of the drivers that's really important in any hospital is the prolonged prophylaxis. There are specialties in surgery that give their antibiotic as a prophylaxis also 1 to 3 days after surgery. And we've looked at that in 52 randomized trials in almost 20,000 patients. And also for today, I've shown you the update we just finished for the Dutch national guideline, and that has 58 studies, so updated from the publication I showed you here in Lancet Infectious Diseases in 2020 of the WHO, 52 trials, and we updated it, 58 trials. And overall, prolongation does not give you a reduction of SSI. And what's most interesting, and if you focus on the bottom part of this table, looking at adherence to current best practice of your antibiotic prophylaxis. Best practice is adequate timing, what I told you, within 2 hours before incision, and per-operative redosing of the prophylaxis after 4 hours or blood loss of more than 1.5 liters. So if you adhere to the best practice, prolonging prophylaxis after surgery makes no effect. The relative risk is 1. If you don't adhere to the best practice, then you can make up for it to prolong antibiotics. But that seems totally counterintuitive, and we shouldn't do that because of the antimicrobial resistance pressure. So if you just do best practice, you don't need to continue antibiotics after surgery, so after the patient leaves the operating theater. And that's the WHO's strong recommendation, not to do that. There's a more one of the most recent papers is a nice study in JAMA surgery on almost 80,000 patients that shows you something else. It's not only that it doesn't work, the prolongation, it gives no additional reduction of the post-operative infection, but there's also a dose-dependent, a duration-dependent, the longer you give it, increase in Clostridium difficile infections and acute kidney injury. So it doesn't help, but it does harm. So we shouldn't do that. Now for the recommendations of prevention here, there's no benefit of laminar flow. 12 observational studies in hip and knee arthroplasty, but also abdominal and vascular surgery. If you look at in red, the upper limit of the confidence interval shows you that there is no benefit from laminar flow versus conventional turbulent ventilation. So if you use your money to improve anything in your hospital, don't put millions of crowns of euros into laminar flow installation. These authors that were part of the WHO group said that it shouldn't be used as a preventive measure and should not be installed in new operating rooms. And that was affirmed by a recent publication in JAMA in a retrospective cohort comparing 2 surgical facilities, one with laminar flow and one without. And they looked at the periprostatic joint infections within a year. And without laminar flow, it was 0.4%, and with laminar flow, it was 0.5%. And after logistic regression and correcting for other factors, it still wasn't significant. So you can save your money and use it for something else. Normothermia is very, 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 very important because if the patient has a lower temperature below 36.5, it increases coagulopathy, blood loss, and with hypothermia of only 1 degree Celsius, you have increased your blood loss by 16% and increased the risk for transfusion by 22%. It gives vasoconstriction and thereby reduced tissue oxygen perfusion. It gives you impaired immune system and a delayed healing because of a delayed collagen deposition. Now, there are 2 good randomized trials, not a lot, but they show you a big difference with warming, for 5.8% SSI, and no warming, about 16%. So very nice reduction using intraoperative warming, but it starts with pre-warming. We start with warming in the holding area and then transfer the patient from the holding to the OR with a warm air blanket. The hyperoxygenation had some debate because in 2016 the WHO recommended that, strong recommendation, to use a fractionated oxygen of 80% instead of the traditional 30 to 35. And then now in the update in 2019, it suggests to use 80%, conditional recommendation because the evidence has shifted. This was the evidence in 2016. If you look at the top panel, because that's the intubated patients, you see the upper limit. There is a significant reduction. The upper limit is 0.94, so almost 1. So almost not significant, but significant enough. And there was a lot of debate over potential harm. There are 2 recent papers coming from the WHO group looking at harm and at effect. There is no harm of fractionated oxygen of 80%, but the effect changed a little bit because now you see the upper limit is 0.99. And that is because 4 studies had to be removed because of fabricated data of one group, which is a real big problem. And there were some additional trials. So this is probably the best we have. And the recommendation was toned down a little bit. Normal volemia is something that most people don't think about, but it's very, very important because it reduces mortality. Having a hemodynamic protocols or goal-directed therapy, goal-directed fluid therapy in your OR reduces mortality by half. That's interesting. And also, if you look at the more recent publications of this century, it has an effect on complication rate, odds ratio of 0.4 for goal-directed fluid therapy. Normal glycemia is something that we have to focus on for diabetic patients, but also for patients without diabetes, because in the stress response during surgery, there is a rise in cortisol, glucagon, catecholamines, and growth hormones, all sorts of hormones. And that causes hyperglycemia due to increased catabolic hormones, also in the non-diabetic patients. And it results in endogenous glucose production, and that combined with the reduced insulin secretion and a transient insulin resistance gives you a transient hyperglycemia that lasts for about 24 to 48 hours post-operatively. And does that matter? Yes, it does, because if you look at this graph, on the left panel you have the intensive protocols that regulate glucose. On the right panel, the studies that don't regulate glucose. You see the red line is the glucose levels. They're lower in the regulating protocols, and also the SSI rate is much lower in the regulating protocols. So you need to regulate your glucose also in the non-diabetic patients. And the final chapter of what we can do is the surgical site handling. Hair removal. Do we remove hair with a clipper, a shave, or no hair removal? If you look at shaving versus no hair removal, it's about the same, but it's in favor of no hair removal. But most important, if you need to remove hair, remove it with a clipper and not a razor. Clipper versus razor, no harm, no benefit of perioperative hair removal. In case of hair removal, clipping is preferred. But there are no recommendations on the timing of hair removal, but to my opinion, it should be outside of the OR. But that's not always possible logistically. So if you do it in the OR and hair goes everywhere, I think it's best to use a smart clipper that immediately sucks out the hair also. For the skin preps, we can choose of chlorhexidine or povidone iodine and combine it with either alcohol or water, and that gives you the different combinations. Now for the disinfection, if you look at the horizontal axis, x-axis is hours after scrub, and you have the log reduction of the bacteria. Alcohol is very quick and has a good reduction, but it lasts for about 2 hours after scrub. And the chlorhexidine gluconate has a little bit less reduction, but lasts very long. So the combination of alcohol and chlorhexidine is the best combination, and that was also the results of a systematic review looking at 12 randomized trials and showing you that it's actually in favor of an alcohol-based solution over an aqueous solution. Having 39 SSIs fewer per 1,000 patients if you just don't use an aqueous solution. But then alcohol-based chlorhexidine is more effective than alcohol-based povidone iodine. So that's the advice. Now there is a confusing advice in the NICE guidelines about skin prep, and it says that the 0.5% chlorhexidine in alcohol should be used for minor procedures and the 2% chlorhexidine in invasive medical procedures. I agree with the higher 2% chlorhexidine, but the reason is because the licensing, the lower concentrations are licensed only for the minor procedures, but that's not a good reason because it is evidence. And I'll show you the recent WADE study, which is a network meta-analysis comparing all these different solutions for skin prep in 17 studies, almost 15,000 patients, and this is a very important force plot. So look at the left one, the random effects model. The higher the concentration in chlorhexidine, the more the square is on the left of the one, because the effect increases when the chlorhexidine concentration increases. And povidone iodine also has 1% contact dermatitis and none for chlorhexidine. So skin prep optimized means use at least 2% chlorhexidine in 70% alcohol instead of the traditional 0.5%, and that's what we recently changed in our hospital. Non-impregnated incised drapes you shouldn't use because it gives you more SSIs, but the iodine impregnated incised drapes give a higher penetration of iodine than the chlorhexidine skin preps give, so you can combine that. And there is some clinical evidence that the SSIs are reduced with iodine impregnated incised drapes, but not with non-impregnated drapes. The wound protectors is for colorectal surgery. Double ring wound protectors give you more reduction of SSI than single ring wound protectors or versus control. So for colorectal surgery, we advise a double ring wound protector. Closure issues, wound irrigation, 7 randomized trials showing if you irrigate, and all the studies are with aqueous povidone iodine, which is actually a pity because I use aqueous chlorhexidine. But well, there you have it. Glove change. Not a lot of evidence of glove change. The only evidence that's there is that the bundles that include glove change have more effect than bundles without glove change pre-closure. But there's no randomized trials with or without glove change. Same is for the sterile closure tray. The meta-analysis shows you that if you have bundles with a sterile closure tray, it's more effective in reducing SSI than bundles without a sterile new closure tray, and that's for colorectal surgery only. Another issue is sutures versus staples. And it's good that we look at the evidence, because I hate the use of staples, but I'm only partially right. Because if you look in red, there are two trials in elective colorectal surgery and elective open GI surgery. So in my field, I'm right. Subcuticular sutures give a lower wound infection than staples, but in one other colorectal study and two other laparotomy studies, it's just no difference, which is a pity, but that's what the evidence shows us. Then there's an abundant evidence of triclosan-coated sutures. We even updated this, but the evidence doesn't change. There's a relative risk reduction of 28% and the number needed to treat of 28, which means if you treat 28 patients with triclosan-coated sutures, you save 1 SSI, which is a pretty good deal. We published that in British Journal of Surgery in 2017, and also compared that with other randomized, other meta-analysis. Other meta-analysis left out multiple trials. We included all available evidence, and also did something that is called a sequential trial analysis, and that means that you look if the evidence is uncertain, that if you would add more trials, if the evidence would change. But the data are saturated. It doesn't matter if you add more trials. This is what it is. And it is a very significant effect in favor of triclosan-coated sutures. The same is for closed incision negative pressure. The 2019 evidence was 28 randomized trials. We recently updated that for the Dutch guideline, 45 randomized trials, and still the relative risk is 0.6. And it stays 0.6 because it was already 0.6 when we did it for the WHO, and that was only 6 randomized trials. So this is what it is. Closed incision negative pressure wound therapy reduces the risk of SSI, and I use that in all my patients. And some technical interventions you can do in colorectal surgery. This was a recent Delphi consensus that we have with a group, and we looked at some technical interventions. And if you just use the same colors as in the beginning, green is what is positive recommendation, brown is a negative recommendation, and yellow is consensus but insufficient evidence. So what works is the wound protectors, the iodine wound irrigation, the triclosan-coated sutures, and the negative pressure wound therapy. This is impressed in the Journal of American College of Surgeons. And what is ambiguous but advised is the sterile incision closure tray and the pre-closure glove change. So that ends with this ideal bundle. And for colorectal patients, you can add mechanical bowel preparation with oral antibiotics, but this is for any type of surgery. Preoperative warming, hair removal with a clipper, adequate timing and redosing of your surgical antibiotic prophylaxis, skin prep with at least 2% chlorhexidine in alcohol, intraoperative warming of the patient and monitoring of the temperature, normal volemia, having a goal-directed fluid therapy protocol in use, hyperoxygenation, glucose control in all patients, wound irrigation with aqueous chlorhexidine or povidone iodine, and no prolongation of your antibiotic prophylaxis after surgery. What is also effective and needs to be part of the bundle, but it needs some investments that pay back because of the reduced SSI, is the iodine incise drape, the closed incision negative pressure wound therapy, and the triclosan-coated sutures. Thank you for your attention.
Thank you very much. It works. I particularly enjoy the fact that you not only tell us what, but why and also in some instances how. There are obviously some organizational issues that I'm curious about because the healthcare systems in every country are huge, and there are so many personnel that need to be informed and trained and so on. Have the WHO done any thinking or added advice on how to introduce these bundles?
Yes, they did. If you look at, you can download the WHO implementation manual, and what it did is exactly what I started telling, is to put it into the surgical pathway. That means that if it's something that's preoperative, you have to decide who's responsible. So it could be the ward nurse or the anesthesiologist in the outpatient clinic or whatever situation you have. And you also have a supervising responsible person. So you don't have to teach everything to everyone, just about the tasks that are a part of your responsibility. And in the OR, there's part is the anesthesiologist, part is the surgeon, part is the scrub nurse. The only tricky thing is that where the purchase department comes into picture, because actually we don't want that. But
who does?
No. But then it's about what does it cost up front. But that's the only thing they can think about. But that's totally not interesting. You have to look at what is the total cost of that patient. And that's much more difficult than only looking at what is the price of a suture. All right, I see, that's like 10 cents less if I do a cheaper suture. But that's totally irrelevant if you look at the bigger picture and the SSIs. The SSIs are, costs of SSIs are extremely high, and the incidence of SSI is extremely high. So it is, for colorectal surgery, it was calculated just recently that in the UK, by implementing a rather simple bundle, but much of what is here could save like 60 million only in colorectal. Easy. And
not counting lives and suffering and so on. This is just the money.
If you want to talk money, but that's I've made to myself a very simple solution to deal with that problem. I don't discuss the costs whatsoever. I only show the evidence, and I say, I'm responsible for my patient. This is what I want, and there's no argument. They can only argue if it doesn't work. If it doesn't work, maybe we shouldn't pay for it. But if the evidence, all the evidence shows me that it works, and I want to use it, I think it's my responsibility for my patients that I am doing that. And it's hard to sell to a patient. If you would ask a patient, do you want me to use something that reduces your SSI, or shouldn't I use it because it costs money? I think the answer is quite simple.
Very much so.
So let's, as doctors, or let's say in broader perspective, healthcare personnel, let's stay away from that discussion. And there's also a discussion of degree in OR, which is also interesting, but it should not tamper with quality.
Please feel free to ask a question whenever it pops up. Yes, Henrik. Please. We don't have. I can repeat the question. For the. Okay, then I can't.
Let me give you this.
That's fine.
This is for our external listeners.
My name is Henrik Malkau. I'm an orthopedic surgeon, been working with registries for many, many years. One of the major flaws in the conclusion around laminar airflow is data from the New Zealand arthroplasty registry. And that study was repeated recently in Norway with a much more detailed mapping and a much more detailed information about SSI outcome, and reversed that conclusion. What is your comments?
That's the good thing with looking at evidence and all the evidence is that I refrain from looking at one study because usually evidence flips left and right and left and right. It's just like a pendulum of a clock. And the only thing that you want is if it stops going left and right, where does it stop? On the left side or on the right side? So one study, there's always, if you say there's evidence against, there will be one study that doesn't show the effect or shows maybe the opposite. It's about aggregated data. And the aggregated data are really, really clear in hundreds of thousands of patients that it doesn't work. And if it works, and I can show you a couple of studies that give you exceptions the other way, it shows that laminar flow increases infection. So if it does anything, it's at least at the wrong side of what you want.
Which papers do you really collect the outcome?
All papers. But that, I know. Yeah, no, I don't think that's wrong, because you do a quality assessment. It's for systematic reviews, and that's for the WHO, but that's for any type of guideline. You use the grade principle. And in grades, you do a quality assessment of all papers. If there's anything, and I can tell you an example, which I said about the hyperoxygenation, we looked at the methodology of papers and we graded that. What we didn't know is that 4 trials of the same author were fabricated data. So, but in the end, everything comes out, and these trials are retracted from the journals, but also from the meta-analysis. You have to have very, very strong methodological arguments to exclude a study. And best meta-analysis includes most or almost all data, because in the end, the point, what we call the point estimate, will tell you what it is. And if you keep adding data and you see that the point estimate flips between significant, non-significant, positive effect, negative effect, then probably there is what we call imprecision. So we just don't know yet, and that's when the evidence is low and the recommendations are also moderate, low quality, and have to be toned down. For laminar flow, because we've done for the last 2-3 years our national guidelines and the discussion, I have to say also with the orthopedics on that point, and I know all the evidence by heart, there is not a shred of evidence in aggregated in favor of laminar flow. But I know orthopedic surgeons like it.
That's not really the case like but we did an HTA, Health Technology Assessment, here at this institution. We did have a long and heavy discussion around making the final conclusion recommendations, but it shows a very weak evidence against using it. So I don't think the data is there still that you can make these strong conclusions.
No, sorry. Correct. The only thing that up to now, it isn't worth any investment because there's no evidence showing its advantage. In our national guideline and same in the WHO guideline, it says that it's good either way if you have turbulent or laminar, because there is no clear difference.
In care bundles, do you study, are there comparisons between care bundles as well being performed? You mentioned that there are groups of care bundles, depending on the political organization issuing them, but you compare them.
There are only different care bundles. I think it will be very difficult to have a study design comparing two different care bundles, because you have to have, if it could not be, I think it can't be done without having complete contamination of one study arm and the other study arm, because you have to implement first before you can study that, and implementing means educating staff and all personnel.
And possibly reorganize.
So that would be impossible. So I think, like in our SURPASS checklist study, we compared hospitals in the same period. We've done a medication error study where we compared departments, but all these issues where you have to involve the entire hospital, it isn't easy. Even in our APOC trial where we investigated our bundle, we randomized it. It was already tricky, but we randomized ORs. Because we are a very, very large hospital. We have many ORs, and we have so much personnel that probably it's kind of random who's there, and the knowledge present is kind of random. So we randomized ORs per day. So OR 1 to 10 got the bundle, and ORs 11 to 20 didn't. Whatever.
I can understand.
But even then, you have contamination between arms, because if you run the trial for long, it becomes normal behavior. So your trial will be kind of an implementation strategy. And actually, with our bundle, we didn't find a huge improvement. We haven't found out exactly why, but some of the more important interventions, the compliance was also not perfect. So I think everything is about having a bundle in place with evidence-based interventions, and then focus on compliance.
That was my next question. How do you assure compliance? Because organizations get tired and sloppy over time. An initial focus increases results or improves results, and then you look at hygiene behavior and so on. It deteriorates over time, and then you do some kind of intervention and it improves, and then it falls back again.
Yeah, I know. But some of the interventions are easy, like use a clipper, not a razor. If you have only clippers in the OR, you can't use a razor. If you want to use triclosan-coated sutures, just have triclosan-coated sutures and remove the rest. If you do a 2% chlorhexidine and alcohol, just put the Chlorpep there, and or maybe only keep the povidone iodine for the colorectal disinfection lower part. Others are
and keeping keeping the patient warm all the way to the OR, sometimes difficult.
Well, that's I think we found a good solution for that, because what we did was having the bear huggers in the holding area. The only thing that the hospital needed to do is to buy, I think, 4 or 5 of the units, the electrical units, to plug in the bear hugger. So every patient gets that. They're when they come in the holding area, they get the bear hugger. They're plugged in. They're kept warm. They like it because they're nice and cozy. Well, sort of cozy in the holding area. They feel secure. That's what patients tell us. And it was only a very small logistic change to have the plug-in device, the motor of the bear hugger in the holding area. And the same bear hugger on the patient goes into the OR, so there's no extra cost. So you take the patient with their own personal bear hugger to the OR. That was so simple that actually everybody liked it, and the holding personnel was the only group that needed to know that they had to put it on. So that was quite easy to implement that. What is more difficult is to have temperature monitoring during surgery, because the anesthesiologist has to regularly monitor temperature, preferably in the esophagus, and thereby adjusting their heated IV fluids, or warmed up, I mean. You can have also a warming device underneath the patient, because you want your end temperature to be 36.5, but also steady.
Yeah.
And hypothermia is so clearly interacted with SSI and bleeding complications that it would be it would be one of the main focuses of implementation. Actually, if you just give everyone a task, it is not that difficult because they don't have to know the entire bundle. You just have to know who's responsible for what. And OR nurses are really, really good if you get them involved. They like to have their influence and positive effect on the team. So, yeah.
Cool.
Get something else. Sorry.
Okay. Thank you for a great overview and presentation of the WHO guidelines. My name is Ola Rolfsson, I'm professor of orthopedics. What were the challenges with trying to make general recommendations for different types of surgery, knowing that there are, I mean, these are very different circumstances, acute versus elective, implant surgeries where you use implants, surgeries where you don't use implants so what were the challenges here?
I think the WHO guideline is the only guideline that takes into account that it also has to work in low and middle income countries, contrary to the CDC and the NICE guidelines. And it also has to work for every type of surgery. So if you read the 29 recommendations of the WHO, you will see that all of these are possible to implement even in low and middle income countries. So, for instance, negative pressure wound therapy, you would say that's impossible in Africa, but it isn't, because we had people from Kenya and from other countries in Africa, in South Africa for amongst others, in the GGG, and they were telling us that it's possible, but they won't use a commercial device, but they would make a homemade device, and they were already doing that because they have the wall suction devices, and so in a way they have ways to do negative pressure. Patient warming will be heated blankets and won't be a bear hugger, but it's not about how you do it. That the WHO doesn't tell you how to do it, but it tells you which interventions are effective and are recommended. So the focus was to have it really global, and some of the guidelines will have a remark of that you have to look at cost issues. Resources. That's not cost, but resources. So if you're not in privileged countries, it may be that you have to focus on part of the recommendations. We didn't have that much issues with the different types of operations, because some guidelines have like different recommendations for prosthetic implants, like the CDC has. Some have different recommendations for cardiothoracic or for cesarean sections. But actually these work for all, and if it's like mupirocin, if it is apparent that the data is only for cardiothoracic and orthopedics with enough certainty, then the recommendation will be in those types of surgery, and there will be a much lower recommendation for other types of surgery. So I found the 3-year process, 3-4 years in WHO, even with my extensive knowledge already of looking at literature for evidence, really eye-opening how, even if we had a discussion about a topic, everything we discussed needed to be written down, why we came to a certain recommendation, but also the remarks that led to the recommendation needed to be noted. It could not be on the fly, never.
Do we have any more questions? Christian, do you have any question from?
Yeah, it seems like ventilation systems is a hot topic. Some of the question we already answered, but ventilation systems, are there any proof that or evidence that it's reducing bacteria? Let me see here. Reducing bacteria in the system.
Well, there is a difference between whether it's laminar or turbulent, but there's also something like how many circulations you have per second or per minute. So you do need, if you look at the evidence, a system that has a high turnover of the air in the OR, so that it could clean it within only a few minutes, and the lower grade systems don't have that, and it takes them a longer time to entirely filter the OR air. But that's different from being laminar or turbulent. And many studies look at colony-forming units, so not infections. If you look at the evidence for infections, there is no difference. If you look at colony-forming units, there is only a slight difference within a laminar plane and outside the laminar plane. And if you then zoom into other factors that influence that, the only, for instance, door openings are also an issue. The number of door openings, and actually the number of door openings it's not about the door opening, it's about the length of the operation. So if you correct for duration of operation, it is a duration, and having longer surgery gives you a higher risk of SSI. So it's the door openings are only a surrogate marker for a longer duration of surgery. So that's another way to think about it. And the colony forming units don't give the answer. It's not SSI.
Number of people in the theater.
Yeah, same. Yeah.
Is it the same as the door openings?
Yeah, if you look at the problem with the number, the studies that register a number of people, that they don't tell you the number present at the same time. They only tell you the number that has been present during surgery, but that's also related to the duration of surgery, because then you get, if my surgeries take all day, so I have 3 teams coming in the morning and then the afternoon, and then there's some kind of in-between team that does the closure part. So it's duration of surgery by and large, and not the number of people present. There is also lots to do about distractions. What is also about music in the OR. It's not good. I use it, so I hope it's good. I recently found it that shows that music is in favor of the outcome of surgery.
Grade 4 study.
Probably.
Ah, yes, we're sure.
Yeah.
Thank you very much. This was really illuminating, and I think there will be a lecture later on today which will be in Swedish, and you will miss it, unfortunately, but it is regarding care bundles, and it was 2 years ago it was presented last time. So we'll see what has happened and what parts of that care bundle uses your components. So we'll see how they work together. But this was extremely interesting and very tangible, and could be. I
hope it works, the bundle, because I'm not really happy with the APOC bundle results. I would have expected the difference to be bigger, but it's not. It is there, but it's not as big as I'd hoped. So we have to look into that.
Oh, yeah, definitely. Thank you very much. Okay.